Good evening, friends. Welcome to this Tuesday evening academic sessions from Yashoda Group of Hospitals. From the Department of Critical Care Medicine and other allied specialties, we try to bring some topics of interest. For the last half a decade or so, from the time of COVID pandemic, the extracorporeal membrane oxygen support has been a new norm in many quaternary care ICUs like us. So we had a maybe more than 308 transfers and many patients who actually were road transferred to us and our own patients who actually received this extracorporeal membrane oxygenation during this pandemic, followed by there is definitely a surge of the awareness, the surge of the request, the surge of its indication across the different spectrum, from not just a support to both the heart and lung, but to the procedures for ECPRs and many more. And on the process of this extracorporeal supports, we have come across new different challenges which are mentioned across this procedure, from difficulties of cannulation to acquiring a blood flow to coagulopathies to infections, and not the least but ventricular dysfunction. So a team which actually gone through this experience and learned across these cases, and we have a exclusive ECMO unit in our Yashoda Hospital High Tech City and Yashoda Hospital Secunderabad, where Dr. Charan happens to actually was happy to exclusively be a part of a ECMO unit and be a ECMO physician, and dedicated his almost last 5 years into the learning, attending, doing the courses and all. So we welcome Dr. Charan for this talk, and we are privileged, honored, Dr. Bindu Akananti being here. And thank you, ma'am. I do understand it's a early part of your day, 10 o'clock, and accepting our invitation. And just a brief introduction to her, other than her background, which she has almost spent 25 to 30 years in circulatory supporting devices. I happen to be her audience in the recent completed Congress of ECMO in Kolkata, and I was really amazed by the way she actually carried that lecture of a 20 minutes. So it brought us to the ground realities that we should take her inputs during our next session. So she was kind enough to accept our invitation and joined us. Thank you, Dr. Bindu, being a part of us today. So the flow of the today's program will be Dr. Charan will take us through the few slides of during our ECMO program, and during our ECMO cases, we have came across the right ventricular dysfunction as one of the common challenges. We came across with some of those pre-existing decompensated, some of them who are already on ECMO decompensated, and that being one of the common challenge which we faced. And Dr. Charan will bring us across the different options we have, and also MCS, which Dr. Bindu probably enlighten us. And we have also spoke about those impellers basically to the right ventricle. And I was also listening to Dr. Rodrigo, who was talking about the air hunger being dropped by that. Probably we'll take those in lights from Dr. Bindu. Before that, I request Dr. Charan to take us through this presentation. Over to you, Dr. Charan.
Thank you, sir. So today we will be discussing about the mechanical circulatory support options in right ventricular dysfunction. So what causes right ventricular dysfunction? So right ventricular dysfunction can occur because of when there is decreased RV contractility, when there is an increase in the RV afterload, or when there is a increase in the RV preload. So in case of patients who develop a right ventricular dysfunction secondary to decrease in RV contractility, we have acute myocardial infarction, ischemia, myocarditis, post-cardiotomy, arrhythmias, with acute decompensated heart failure kind of picture, where we all know that the conditions which are causing increased in the right ventricular afterload is pulmonary thromboembolism or pulmonary diseases, especially cor pulmonale. Positive pressure ventilation sometimes can increases the RV afterload, but it sometimes can actually tilt the balance towards RV failure. The most common cause of RV dysfunction being the left-sided heart failure, or if the patients who are having biventricular dysfunction and the patient is put on an LVAD, then their right ventricular dysfunction is unmasked, or when there is any chronic pulmonary hypertension which is decompensated. The causes of RV preload, increase in the RV preload includes acute renal failure when the patient is in fluid overload, acute right-sided valvular failures, patent foramen ovales and all. So RV failure, so ideally can be basically classified as isolated right ventricular failure or a biventricular failure. So what are the various criteria to diagnose an RV failure? It includes the hemodynamic criteria as well as a echocardiographic criteria. The hemodynamic criteria, how to actually diagnose a case of right ventricular dysfunction is that when we measure the cardiac filling pressures, we can go for pulmonary artery pulsatility index. We can go for pulmonary vascular resistance, transpulmonary gradients, which is considered like less than 4 is considered normal, diastolic pulmonary gradients, RV stroke work index, PA compliance, etc. So these are all actually calculated with the help of a cath study. So when we are able to understand the pulmonary capillary wedge pressures, PA systolic as well as diastolic pressures with mean pulmonary artery pressures, we can ideally calculate these gradients based on the cardiac output, based on stroke volume and mean pulmonary artery pressures, pulmonary capillary wedge pressures, pulmonary artery systolic and diastolic pressures. So based on the information we get from the right heart cath, we can identify these parameters, and after these parameters are identified, we can actually classify as RV failure or RV dysfunction. Now, what are the echocardiographic criteria? Where majority of us we actually use an echocardiographic criteria to diagnose RV failure because cath study can be cumbersome in all these patients. So when there is RV end diastolic area to LV end diastolic area is more than 0.6, normal being 0.6. When there is less than 35% of RV fractional area change, when you have RV free wall strain, it varies by study and population. When we have Doppler velocity, normal is more than 10 centimeters per second, it's less than 10 centimeters can be considered dysfunction. TAPC, tricuspid annular plane systolic excursion, and TAPC by pulmonary artery systolic pressures. So it actually is helpful for us to identify RV and PA coupling or electromechanical discoordination. So when do we actually take a decision to mechanical circulatory support in patients who are having RV dysfunction? So not all patients, obviously we know that any patient who develops RV dysfunction either on ECMO or because of any of these isolated causes need not be directly placed in the decision to place mechanical circulatory support. Unfortunately for us, there is no actual criteria which are very specific for right ventricular as opposed to left ventricular in cardiogenic shock. So we can actually take the classical SKY classification which we are using to define cardiogenic shock, and these patients who are having severe cardiogenic shock like D, C and D, classic in the beginning stages like classic stage and the deteriorating stage, the decision to MCS comes into play. Whereas in patients who are having stage E extremis, it is always to go for extracorporeal cardiopulmonary resuscitation. So majority of the cardiogenic shocks in the late C and D phases are the patients who benefit from a mechanical circulatory support. So we have established that the patient is having cardiogenic shock. That is number one. Second, we have established that this patient will be having a SKY C to SKY D cardiogenic shock. And after we have actually established these, we will go for evidence of right ventricular failure. So we know that these patients can be profitable, like it can be actually getting better with a MCS support. And then we find evidence of right ventricular failure where CVP being a classical indicator, we know that there is a decrease in cardiac index. There is CVP per pulmonary capillary wedge pressures of greater than 0.63. And if the patient is having significant vasopressor or inotropic use to maintain the systolic pressure greater than 90. In this case, we also have to look for are there any contraindications to a possible mechanical circulatory support. This include multidisciplinary, we have eligibility. So we have eligibility for mechanical circulatory support. There is a shock team evaluation. Then we have to identify what are the goals of care. It is a bridge to transplant? Is it a bridge to recovery? Is it a bridge to decision? And then we have to also identify are there any contraindications for this establishment, for the institution of mechanical circulatory support, which includes end-stage diseases. End-stage diseases like malignancy where the patient might not be much profitable in spite of initiation of mechanical circulatory support of any kind actually. Then we have to also identify, is there any evidence of LV failure? We can go for the hemodynamic as well as the echocardiographic criteria is of finding, is there any evidence of an LV failure? Because sometimes if the patient is having LV failure and LV failure is a reason for his axial shock, a patient placing him on a temporary LVAD can actually help him, but it can actually unmask a right ventricular dysfunction later, and we will be discussing that in the further slides. So if there is no evidence of LV failure or very less LV failure, and majority of the cardiogenic shock is caused because of right ventricular dysfunction, we have to go for RVMCS implantation. So what are the types of mechanical circulatory support which we can institute for a right ventricle? These include direct RV bypass devices and indirect RV bypass devices. So the direct RV bypass devices directly drain the blood from right atrium or right atrium and return it directly into the pulmonary artery. So these include, obviously, when there are surgical RVADs which can be placed, or a percutaneous RVADs which can be placed. The surgical RVADs include direct surgical cannulation of RA and PA, which is connected to an extracorporeal pump. However, we also have the advantage in this scenario where we are directly surgically cannulating the RA and PA. We can already have an oxygenator in the middle so that we can even oxygenate the blood. However, the other percutaneous RVAD devices include Impella RP, Impella RP Flex, a Protec Duo cannula, or a tandem heart Protec Duo RVAD, which is connected to an extracorporeal pump. So Protec Duo and tandem heart also have an advantage where we can connect an oxygenator and we can oxygenate the blood. So because they are directly emptying the blood from the RA into the PA, we can say that these devices decrease the RA pressures. They increase the mean pulmonary pressures, PA pressures, because of the increased pulmonary blood flow. And because of RV dysfunction, the LV filling comes down. And now that we are increasing the mean PA flow, we are also increasing the LV filling by augmenting the right to left transit. And this also directly causes increase in the cardiac output without direct effect on the arterial pressures, because we are not essentially influencing the LV afterload. So what are the indirect RV bypass devices? Indirect RV bypass devices directly drain the blood from the RA and return it to the systemic arterial circulation. So it essentially provides biventricular support, but because we are bypassing the entire pulmonary circuit, we have to oxygenate this blood. So the only indirect RV bypass device which we know so far is a VA ECMO. So hemodynamically speaking, VA ECMO decreases RA pressures, but it increases LV afterload. It also might or might not causes any change in the cardiac output, as we know. It decreases the mean pulmonary artery pressures. So there are actually changes in the overall hemodynamic profiles if we are using a direct RV bypass device or an indirect RV bypass device. So how do we take a decision on what MCS to be placed in these patients? So right ventricular failure with cardiogenic shock. So we have established that there is cardiogenic shock, SCAI, CD, no LV failure, or right ventricular failure is already present. So we have to look for any untreated left ventricular failure. At the same time, we have discussed about the evidence of right ventricular failures criteria and also for the eligibility of mechanical circulatory support. So if at all any surgical intervention is planned because of left ventricular failure already present, or if the patient is going into a durable LVAD kind of thing, we can already place him on a BiVAD with the help of a CentriMac surgical cannulations. Like surgical cannulations include direct cannulation into the RA as well as in the PA. We can use a HeartMate 3 LVAD, which is not strictly licensed for as an RVAD device, but it can be used. Okay, or an isolated right heart durable mechanical assist device. However, if the patient is not planned for any surgical intervention, we can go for a VA ECMO or a ECMO plus Impella to decrease the LV afterload. However, if the patient is having impaired gas exchange, then it is important that we are oxygenating the blood. So these patients have to be placed with an oxygenator in the VAD. So these are called oxyvads. We can go for Protec Duo RVAD or a VA ECMO. If the gas exchange is okay and if the patient is oxygenating well, then we can go for percutaneous direct RV emptying devices, namely Impella. We can even go for a VA ECMO, or we can go for a Protec Duo RVAD without an oxygenator. So, because we are actually discussing about majority of these patients are majority of these RVAD devices are microaxial linear flow devices, because these are non-pulsatile flow devices. These non-pulsatile flow devices obey what is known as a HQ curve. So what is H and what is Q? H stands for the pressure difference between the ends of the ventricular assist device which we are placing, and Q is the device flow. So essentially speaking, the device flow is inversely proportional as opposed to normal blood flow, where it is directly proportional to the pressure difference between the inlet and the outlet. Here, a non-pulsatile ventricular assist device, they are inversely proportional to the pressure difference between the inlet and the outlet. So we can actually see here that as the pressure difference decreases, so you can actually see that there is a pulmonary hypertension patient where PA is 50/30 and RA pressure is 20. We can see that the PA minus RA comes to around 30, and at 30 the device flow is less. It is hardly around 1 liter per minute. But as the RV as the PA pressures come down, it has come down to 30/20 because of acute RV failure, where the RV is unable to produce adequate PA pressures and RA pressures remain quite the same. We can say that because of the H comes down, that is the pressure difference between the two ends of the ventricular assist device comes down, we can see that this device flow increases. But this is true in case of non-pulsatile ventricular assist device. Or most commonly, we'll be using this in microaxial flow pumps like Impella. Now, what are the various kinds of ventricular assist devices we know? So I was actually talking about Impella RP. So Impella which has to be placed through the femoral cannula, femoral vein, and then we have the Impella RP flex, which can be placed into the which can be placed through the jugular vein. We have a surgical VAD where we can see that there is a direct cannulation of the RA as well as the PA. Then obviously we have the VA ECMO, which can be a central cannulation from the RA to the aorta, or a peripheral cannulation from femoral venous to femoral artery. Now coming to the individual areas or the individual right ventricular assist devices which are available in the market. So the first thing is the Impella RP. So Impella RP is you can actually see that it has a unique 3D cannula design for us to help in deployment from the femoral vein through the IVC, and from the IVC it goes into the right ventricular and into the pulmonary artery. So there is an inlet area, there is an outlet area. The shape is such that it actually negotiates that curvature, and it has a 22 French pump motor. So what are the features? Typically, Impella RP is a percutaneous microaxial flow pump which flow rates of up to 4 liters per minute. So it's composed of a 22 French impeller, and it's mounted on a 11 French catheter. But we will be requiring a 23 French P-level sheath through which it's a single transfemoral venous access, where we place a 23 French P-level sheath, and into this 23 French P-level sheath we place the 11 French catheter, and it is composed of a 22 French impeller. So it is positioned at the level of IVC, and the outflow inflow is positioned at the level of IVC, and the outflow is positioned at the level of pulmonary artery. So it is actually licensed for use for 14 days. Now coming to Impella RP Flex. Impella RP Flex is the only disadvantage with Impella RP is that because we are using the patient's femoral veins, the ambulation is not quite possible if we are using Impella RP. However, if we are using Impella RP Flex, which is a recently got a pre-market approval from FDA, which was also licensed for 14 days in RV failure, it's implanted through single venous access via the internal jugular vein and 11 French indwelling catheter. We have 11 French indwelling catheter, and because we are actually supporting the patient through a right jugular access, the patient can be mobilized if the patient is on an Impella RP Flex. The various contraindications of using any Impella per se are mechanical heart valves, severe valvular stenosis or valvular regurgitation, especially of the right heart, tricuspid or pulmonary valve. So if there is any interruptions in the right atrium or in the vena cava, or anatomic abnormalities which precluding insertion of pumps, present of DVTs, vena cava filters. So these are the best known known contraindications of initiating an Impella support. So what are the benefits? So what are the studies or what are the research we have for a percutaneous ventricular assist device in Impella RP is the recover right study. The prospective recover right study is actually showed that we can see on the right side that patient's individual cardiac indexes from pre-support to post-support on support has significantly increased. You can see that the cardiac indices of these patients has significantly increased with a statistical significance, as well as the patient's central venous pressure has shown significant decrease or statistically significant decrease in the after initiating the patient on Impella RP. Now, what are the various adverse events which can happen? The adverse events include bleeding manifestations, which can happen in around 18 to 20% of patients, and that is the most common complications that was seen. Hemolysis is around 4 to 5%, and other than which not much complications are actually described. Now, what is a tandem heart Protec Duo RVAD? So, tandem heart Protec Duo RVAD is a continuous flow centrifugal pump that provides direct RV bypass. So, what are we doing here is that it can be done in two methods. Where because it's a, if at all we are talking about a Protec Duo RVAD, what we are talking about is a specialized dual lumen cannula which consists of two ports, one drainage port and one return port. The drainage port lies in the RA, the return port lies in the PA. So a pulmonary artery PA catheter is placed, a guide wire is placed across the PA catheter, then a PA catheter is removed and a cannula is slowly negotiated over the guide wire, ideally under fluoroscopic guidance or a TE guidance. And then after this is placed, this is connected to a externally placed pump, centrifugal pump. And after this externally, with this, what are we able to do is that we will be draining the blood from the RA and directly giving it into the pulmonary artery. So this, if at all we are giving without oxygenation, it is called a Protec Duo RVAD. However, if at all we are oxygenating this, it can be doubled as venopulmonary artery extracorporeal membrane oxygenation. However, if at all Protec Duo, if at all a single double lumen cannula is not available, we can also go for dual cannulations where one cannula is placed via the femoral vein and the other cannula is placed directly into the pulmonary artery, either surgically or percutaneously. So in these scenarios, we can also run a venopulmonary artery ECMO, or without an oxygenator, it doubles down into a right ventricular assist device. There is another cannula called the spectrum cannula, which has three ports, where one port lies in the RA, one port lies in the RV, both are drainage ports, and the return port lies in the pulmonary artery. So it can give flows of up to 4 liters per minute. And then it is obviously, if at all we are using the specialized cannulas, it is a single axis, single puncture, single axis devices. And depending upon the location of inlet and outlet ports, these cannulas can provide right-sided support. So because they are essentially bypassing the right ventricle. So they can also be used along with an oxygenator. That is one of the major advantages with the tandem heart of the Protec Duo RVAD. However, we don't have that advantage when we are using with Impella. So there is actually a registry mechanical circulatory support for right ventricular failure. So there is a tandem heart and right ventricular support registry. So it was actually shown that there is a significantly increased with using of tandem heart RVAD. Improved hemodynamic status is there, increased cardiac index, reduced CVP and pulmonary artery pressures within 48 hours. So we can actually see that the mean pulmonary artery pressures, right atrial pressures, pulmonary artery systolic pressures, cardiac index, everything has gone for the good, have improved with reasonably good statistical significance. And we can also see that there is an improvement in the mixed venous oxygen saturations. So next, coming to the indirect RV devices, RV support devices, which includes veno arterial ECMO. So it rapidly unloads the venous system, but the only disadvantage is that when we are using a veno arterial ECMO, we are essentially bypassing the entire RV and the pulmonary tree. We are directly giving the blood into the aorta. So it definitely can cause increase in the left ventricular afterload. However, when the increase in the flow is, if we are running our ECMO with significantly higher flows, we might essentially decrease the pulsatility of the entire PA system. So there might be leading to pulmonary stasis. Okay, and if at all this patient also develops significant LV dilatation or LV increase in the LV afterload, this can cause LV blood to be stasis in the left ventricle, which can be transmitted back and cause pulmonary edema. We can see post-capillary increase in the pulmonary pressures. So in case of elevated pulmonary vascular resistance because of pulmonary hypertension or chronic thromboembolic pulmonary hypertension, VA ECMO can be a preferred option because it can bypass both the RV as well as the pulmonary tree. So we can also use VA ECMO as a bridge to transplantation or pulmonary endarterectomy, because this has an advantage where we can even pulmonary hypertension, severe pulmonary hypertension patients also we can use a VA ECMO. However, if we are using a directly acting right ventricular assist devices, if the patient is having severe high pulmonary hypertension, our right ventricular assist might not be as much as we hoped it would be, because the PA system would again give so much resistance to the blood flow across the pulmonary tree. So in patients who are having severe pulmonary hypertension, where very high pulmonary vascular resistance, veno arterial ECMO, thus bypassing both right ventricle as well as the pulmonary artery or pulmonary tree, can actually help in improvement of the patient. So how do we actually see the effects of VA ECMO as well as Impella, that is direct versus the indirect methods of RV support? So we can actually see, if you look at the Impella part, that is on the right side of this picture, it does not change much in the stroke volume. The volume of the stroke volume slightly increases because we can actually see that this volume have increased. The blue one is the baseline as well as the green one is the Impella RP. We can see that for the same pressures, we can see improvement in the LV volumes because increase in the pulmonary blood flows, and we can also see that there is increase in the LV preload. So because of the increase in the LV filling pressures, we can see that there is improvement in the total end diastolic volumes. Stroke volume might remain fairly constant. However, in case of RV volumes, in cases of an Impella, you can see that the stroke volume of the RV, the native stroke volume of the RV, significantly comes down. Okay, compared to the baseline, the stroke volume of the RV significantly comes down. However, if you are using a VA ECMO, we can see that there is increase in the pulmonary vascular resistance, increase in the LV afterload, thus increasing the LV stroke work. But it does not change much in the, it is not actually causing much changes in the RV pressure volume loops. So what are the various hemodynamic effects of acute right ventricular mechanical circulatory support systems? It depends upon whether we are dealing with an isolated RV failure or a biventricular failure, as we have discussed in the initial part of our talk. So the thing is, if at all any RV mechanical circulatory support device essentially will cause a decrease in the right atrial pressures. The Impella and RVAD, Impella as well as TH-RVAD can actually cause increase in the mean pulmonary artery pressures because it increases the pulmonary blood flow. Whereas VA ECMO will cause reasonable decrease in the pulmonary artery pressures, but at very high flows when we are essentially causing LV dysfunction secondary to high afterload, it can cause increase in the pulmonary artery pressures. But the thing is, most of the times it will cause decrease in the mean pulmonary artery pressures. However, in case of biventricular failures, even VA ECMO will cause increase in the PAP because, as I was telling, by increasing the LV afterload, it is essentially causing increase in the PA pressures by causing the increase in the LA pressures as well as that gets transmitted back into the pulmonary circulation. So we have pulmonary capillary wedge pressures. If at all it is an isolated RV failure, capillary wedge pressures because of the same reason will increase in Impella as well as in Protec RVADs, whereas in VA ECMO we are decreasing the pulmonary capillary wedge pressures. However, they can increase significantly high if the patient is having biventricular failure because we are essentially flooding the left ventricle on a failing left ventricle. So that is the reason if we are increase across the pulmonary PA flows to a failing left ventricle can actually cause acute rise in pulmonary capillary wedge pressures and left ventricular end diastolic pressures. So LV afterload will be increased in VA ECMO. We know that. However, in case of biventricular function, as I was telling, it can by increasing the flow, they can cause increase in the LV afterloads. So how do we actually wean after we have initiated the patient on a mechanical circulatory support? So what is the decision tree for us to initiate weaning? So right ventricular temporary mechanical circulatory support devices, we'll find out if the weaning is clinically indicated. That is, if the patient's native function has improved or if the end organ functions have improved. So we have clinical criteria where we use mean arterial pressures, heart rate, use of pressors, arrhythmias, urine output, etc. We have hemodynamic criteria, which includes CVP, cardiac index, PA saturations, pulmonary artery pulsatility index, and all. So then we look for echocardiographic criteria as well as the laboratory criteria. So laboratory criteria is essentially for us to find out if the other organ functions have improved or not. The echocardiographic criteria includes the fractional area changes. We will see for the tricuspid annular place systolic excursion. We look for how is the interventricular septum behaving, RV-LV ratio, etc. So if the meets the clinical hemodynamic echo as well as laboratory criteria, we'll go for a weaning trial. So then after we start a weaning trial, one thing what we have to remember is that because we are essentially decreasing the flows across all these RVAD devices, namely Impella, Protec Duo, VA ECMO, or surgery, the patient should be adequately anticoagulated to prevent the thrombosis of these devices, because the less the blood flow we are coming down on, the more the stasis, and the more the stasis, the more the chances of clot formation. So essentially speaking, or any of the RVADs, we will be decreasing flow decrementally by around 0.5 liters to 1 liter per minute. and then we will wait. And if the patient shows evidence that he tolerates coming out of these ventricular assist devices, then we will go for decannulation from the VAD devices. So after decannulation, we'll again go for the reassessment on how is the patient behaving. So we'll essentially expand from these VAD devices. So to summarize the overall picture of what needs to be done in a patient who is having an acute RV failure or RV dysfunction, we have to, first of all, whenever the patient is having RV dysfunction or a cardiogenic shock secondary to RV dysfunction, we always look for LV function. So after the LV function, we have to treat for any reversible causes. So if the patient is having arrhythmia or hypoxemia, metabolic acidosis, hypercarbia, which can cause increased PA pressures and thus RV strain, we have to correct all these correctable parameters first. So if the patient is developing like pulmonary embolism, or if the patient is having a RV myocardial infarction, treat the cause first, and after we have treated the cause, establish the hemodynamic data, establish the hemodynamic criteria that your RV is isolated, whether or not there is isolated RV failure or significance of like the severity of the RV failure can be established by doing a CAT study. So after that, optimize preloads, inotropic supports, add pulmonary vasodilators, mechanical ventilatory supports, and if the patient is still worsening, then initiate RV mechanical circulatory devices. So after we initiate the patient on RV mechanical circulatory devices, we have to identify or anticipate the need, whether or not we need an oxygenator. If at all we need an oxygenator, the patient should go on VA ECMO or tandem RVAD or a Protec Duo RVAD or venopulmonary artery ECMO. Or if the patient does not require an oxygenator and he is able to oxygenate well, then we can go for Impella devices. Or if the patient has developed biventricular failure or the patient has developed LV failure, we have to consider adding LV mechanical circulatory support also. Most of the times, what happens if the patient is having a biventricular failure or with LV predominant heart failure, we go for a left ventricular assist device of any kind. And because of increasing the flow across the LV, it can overload the right heart. So sometimes what happens is that because right ventricular dysfunction is unmasked with the placement of left ventricular assist device, then RV in this patients who are already on LVAD, these patients have to be first RV has to be trained. So RV has to be trained, and then based on that, after the RV is adequately trained, we will slowly wean off the right ventricular assist device. The one more common cause where the patient might develop significant RV dysfunction secondary after placing of a left ventricular assist device is that because of the increased suction force in the negative pressure inside the LV, it can actually cause the interventricular septum to push into the LV kind of thing. So which can change the architecture of the ventricles, and it can cause RV dysfunction. So placement, adjusting the flow rates of the left ventricular assist device is also equally important, albeit maintaining good adequate preload. Thank you.
Thank you, Charan, for that overview. Almost you tried to summarize. So before I will come to you, let me introduce Dr. Bindu Akanti. Ma'am, welcome you back after this session. So Dr. Bindu is the director of both heart and vascular.
It's okay. You've given me such a nice introduction. I get embarrassed.
Of Texas Medical Center. So she carries a vast experience. I happen to be privileged and honored to have an interaction with her. So, ma'am, we have an audience who are from intensive care background. Many of them do practice ECMO on and off in many of their centers, but there is a heterogeneity. Some of them do a regular one, some of them do on off and on occasionally. There is no hub and spoke model. Many of our units in a tertiary quaternary care centers, they do get one or two ECMOs on and off. So first of all, before we go to the details of it, what is the prevalence incidence of RV dysfunction we see in both the categories, VV or a VA ECMOs? Because we spoke a lot about LV dysfunction,
Yes.
LV strain, LV outlet, all that stuff. But what is the prevalence of this?
So I'm going to start out. Number one, great job, Sri. That's a very comprehensive topic. And I think I want to start out with one of the things that ties ICU doctors together is we love complex situations because these are puzzles that we want to solve. I think it's a little bit of egocentricity in there, but nothing excites us more than RV failure, right? You have a patient with STEMI, cardiogenic shock, LV is down, isolated LV failure, boom, done. You can put them in one bucket. Global shock, like by V dysfunction, you're like, okay, the heart is failed for whatever reason, like myocarditis. You want to support them with veno-arterial ECMO as a bridge to recovery, done. That's an easy population. But the thing that ties us independently, whether you're doing VV ECMO, pulmonary vascular diseases, right? Something like, massive PE and things of that sort. LV failure, in my unit, the prevalence of RV failure is probably almost like 30 to 60%, depending upon the flavor of the week. We used to be, just like you guys, we used to be a predominantly VA ECMO program. I have a 20-bed ICU. We have 4 ICUs. One of the ICUs where the sickest patient comes to, including heart and lung transplants, about 20 beds. It used to be at least 5 to 10 VA ECMOs. But over the last 5 years, since Impella 5.5 has come into the market, we have been very diligent in taking patients and immediately getting them off ECMO. Because while ECMO combines our interest and stabilizes the patient, you all know that once you are on VA ECMO, it's a ticking time bomb, right? Whether it is limb ischemia, oxygenator-related issues, SIRS, hemolysis, name the complication, it happens, right? So VA ECMO, even though it is exciting to be in the field, it's a huge burden, and only an ECMologist knows, right? It's great in the first 6 hours, the family is like, oh my God, thank you for saving our loved one. And you're like, okay, please don't thank us until we see them in clinic, because you and I know every day is a ticking time bomb. The way we look at it is very similar to how Sri suggested it. But I want to offer you all an alternative approach to it, which is today we're talking about that algorithm that Manpreet and Ryan Tedford, a very elegant algorithm that was presented in JHLT. But remember, 15 years ago, when you just looked VA ECMO for cardiogenic shock, we talked about LVEDP elevation, but we were like, oh, VA ECMO is it. But now if you stand on any stage and say VA ECMO for LV failure, you're going to be like, do you even know physiology, right? So similarly, I know economics are an issue, not just in India, by the way, America as well, especially with RV failure devices. But I want us to go in with the attitude, we probably only know 20% right now. We have a long way to go. Because if we really know 80 to 100%, we shouldn't have a mortality of near 70 to 80% in a patient that comes in with SCI-E shock with profound RV failure, right? So I want us to go in with a more liberal attitude of we actually don't know what we're doing. We're playing around with machines. We're playing around with the idea that we may get it right, okay? And I want to tell you this because number one, patient comes in, we'll go, I think, each scenario. Patient comes in, 35-year-old, RV is humongous, TAPC is near non-existent, full-blown TR, gigantic pulmonary arteries. Patient has LV that is almost LVOT obstruction because of hyperdynamic, because of the profound, acute, severe RV failure, okay? Patient AST, ALT are in the thousands. The patient has clear lungs, right? So in that case, it's straightforward. This is more than likely a pulmonary vascular disease, a patient with severe PAH. Though now, which RV assist device will you use? So in that sense, we go preload, squeeze, afterload, rhythm, pericardial constraint. Those are the 5 things that we look at when we go into the room with RV failure. What is the CVP? Squeeze, what is your PAPI? PS systolic minus diastolic divided by CVP. What is your PVR, the afterload? We don't really emphasize the amount of PA systolic pressure because Sri had just taught you that the CVP is elevated, PA systolic actually drops. So what you really want to have a general gestalt for is what is the afterload in the sense, what is their chronic afterload and what is your acute situation? Is the rhythm gone? Is the patient already in a flutter? Is the right atrium gigantic? Are you seeing tons of PACs? You know that the boat has left, right? In that setting, if you have the world's best device, the most expensive, let's just say that it's either an RVAD Protec Duo or an RP Impella, the minute that you lodge it, because of the high resistance, you're going to get pulmonic insufficiency and your RV will acutely get worse, not better. Because if you're trying to bypass from the RA to PA, but the afterload is high, what benefit is a RA-PA bypass going to do? Right? You're going to pour blood into a high resistance thing and blood is just going to back off and then you're going to have worsened RV failure. So in that situation, you want to suck blood from the right atrium and putting in the aorta. You want to bypass the PA completely because the resistance is high. So in states of high pulmonary vascular resistance, the only available device to salvage that patient is a veno-arterial ECMO in present scenario, okay? You can do even a RALA bypass, such as a tandem heart, because if you go in and suction blood right from the left atrium, the blood needs to come in from the lungs into the left atrium, so you won't be able to do the tandem. So the only device in that situation is a VA ECMO. There is an alternate device you can use in that situation if you want to stabilize the patient, because the patient doesn't need veno-arterial ECMO. You just need an RVAD. And so that's the reason you're doing VA ECMO. But if the patient is in shock extremis, then we have done a lava ECMO, which is you put in the cannula across from the right atrium into the left atrium, and then you suction both ports so that you have BiV support. So number one, high PVR, no RAPA bypass. You either do VA ECMO or lava ECMO. Those are your only two processes. Now, same patient comes in, 35-year-old, young woman, florid lupus myocarditis, florid LV and RV dysfunction, and the patient needs support. Veno-arterial ECMO is always the right answer. Middle of the night, you can stabilize the patient. You can come back in the morning and then just go, okay, where are we? Where is the AST, ALT? Am I dealing with an isolated LV failure, RV failure, or together BiV failure with PVR state and an oxygen issue? In the myocarditis state, we typically just leave them on VA ECMO. That's a great case for less is more, okay? You want to support them, take care of the plex, take care of the myocarditis, let the LV recover. Yes, it's an LV afterload may increase, but usually the EF, when it comes back with a bang, and then you can decannulate the patient. Third situation, patient is a 72-year-old gentleman that has had ischemic heart disease, has had burnt out LV myocardium, is just walked into your ER, walked into your ICU with what you thought was isolated LV failure, but the patient is now in shock extremis. Same situation, right? You put them on VA ECMO and then you say, do I need LV venting? But when you do an LV venting, I know economics is an issue. Let's assume you put in an LV sump or whatever device that you have access to, an Impella, for instance. It may chatter if the right side is not supported. But right now it's supported because you have a veno-arterial ECMO as a right side assist device and an Impella 5.5 for the left side. But if your lungs are normal, why do you need VA ECMO? Can we not just do an isolated RV support device, right? You have a VA ECMO, which is an RVAD, but it doesn't allow you to move the patient and do of those things. So sometimes in those scenarios, we may consider a bipella, which is the 5.5 Impella on the left side, and then drop the right side device, okay? And those devices for the right side, you can have any configuration of RAPA, whatever is economical to your center. The axial flow device that is available right now is a RP Flex, which is an IJ, or the femoral. We rarely use the femoral RP Impella since the Flex has come into it. But the axial flow devices are also limited. You saw the HQ curves. They cause hemolysis because if you're already on 5.5 Impella, you're already getting a little bit. You shouldn't have much hemolysis. But if you can avoid, if you can manage medically, that's great. But if you don't avoid, if you can't do it, then you have the RP flex, which is an RVAD, which is a RAPA axial flow. So in my head, the way I teach is every pump is either inside the body or outside the body. Either you're intracorporeal or extracorporeal, okay? Intracorporeal right-sided device, you only have one. So RP Impella, that's it. So that's easy to remember. Intracorporeal right-sided device, there is only one axial flow, percutaneous device, RP Impella. If you want this guy to go home, yes, you can put the HeartMate 3 in the RAPA position. We've had this many survivors, okay? It's one for the books. Either the ones that they did at other centers were done so early that they survived to transplant. Anytime we've done it in a shock state where the RV was gone, even when we bridged them, none of them made it. It's a very difficult, it's not the surgical aspect, it's just a difficult. HeartMate 3 on both sides is not as easy as it sounds in the books, okay? So what we do in those cases is either the intracorporeal or the extracorporeal. So what are our extracorporeal devices in that setting? We already talked about VA ECMO, which is extracorporeal centrifugal device, right? The second one is a RAPA. You could do, like for instance, a Protec Duo. There's one cannula that's suctioning blood from the right atrium, and the second one is delivering it into the PA. Centrifugal pump, very small centrifugal pump. And if you need oxygenation, you can put in an oxygenator, and it is basically a VV ECMO with an oxygenator, right? With RV support. Now, we were actually the very first ones that did Protec Duo for post-LVAD RV failure in our center. And in the beginning, the blood was just like the cannula was not long enough. So we got a lot of pulmonic insufficiency. And then the second thing is, even though the FDA regulates most of these devices for hours, 7 days, 14 days, these devices, with the blood flow and the warmth, they can crack. They're not as durable as you think they are. Especially the Protec Duo, it kind of, even if it is a little bit of a kink, and if you stay in, and then we mobilize our patients with Protec Duos all the time, they can have breaks too. We do it, no question. Okay, that's a percutaneous device. Let's say the same guy, 74-year-old, not a transplant candidate, you do want him to get an LVAD one day, and the RV did not recover. So the next approach is an intermediate device, and we use those same centrifugal pump, and then we do a CentriMag. So a direct cannulation, right atrial and PA. The cannulas come out, they literally stay on the table, and the guy is walking around. We've had it for like 2 to 3 weeks, sometimes even as high as 6 weeks. And when the RV recovers, it's a bridge so that we take it out. And how do we wean when we have this? We, exactly as Sri said, we come down by flow. Then we look at CVP. Then we look at, because we don't, with an RVAD, it's easy to say we look at the metrics, but it's very difficult to have an RVAD and a PA cath, okay? The Impella allows you because they're not that big, but when you have an RA, PA, bypass, and cannulas coming out, and then the swan. Yes. So we look for AST, ALT, right? It's a great, if the liver is working well, it will tell you what's happening to the RV. We look at AST, ALT, if the CVP, day one, you're aggressive, you do CVVHD, I want to go down on flow the next day, and then following the AST, ALT went up, your vein didn't work, you go back on support, okay? And it's a dance that we play literally all day long. Have people walked out? Absolutely. Does it take an ICU team that believes in it? Absolutely. It's a long dance. So CentriMag, RAPA, probably in our opinion, is the most powerful RV support device that you can do for isolated RV failure that is intermediate in nature. Like we're talking weeks, 2 to 6 weeks, okay? You don't need to put in an oxygenator because the lungs should not be an issue. The only time the lungs become an issue is if you're late in the game, right? You put the guy on VA ECMO, the LV afterload has been increasing. We sat on the patient with VA ECMO. Now it's no longer a VA, no longer just a heart problem. We have created an iatrogenic VA ECMO-induced lung problem, right? So if you vented the LV, because we were here 13 years ago. I haven't been in MCS for 20 years. Dude, that makes me like 55 to 60. I'm young still. I've done this as an attending. I've been leading the unit for about 13 years now. And in the beginning, we used to call it ECMO lung. We were very like excited. We're like, oh, the lung is increasing, haziness, opacities. This has to do with the oxygenator. Now we know, we put a 5.5 Impella in, nothing happens to the lung. Nothing. The lung is crystal clean, black. So it was all along pulmonary edema. It was all along pulmonary edema. It was probably the secondary pulmonary lobule was just completely effaced from outside in. So you have to vent the lung. You put the patient on VA ECMO. We keep talking about LV venting. Think lung venting. Are you really truly making the lung dry, right? So then that's it. You have either intracorporeal or extracorporeal. You don't have that many devices to play with. And a durable, the true only one that you can go home with on the RV side is right. It's HeartMate 3 on the right side. But remember that in the world, we're not just India and America, right? If there is a baby, then you have the Berlin heart. Syncardia, which is a total artificial heart, is still on the market. There's the 50cc and a 70cc. And Bivacor, which is developed in Australia, they just used it across. So we're right now on Fannin Street. They just used one last year here on at Texas Heart, which is a different hospital than me. They put in 4 of them, and it supports the LV and the RV with a singular motor. So it's like the motor is in the middle, and it's churning, and it's suctioning blood to the RV and sending it into the PA, into the LV and sending it into the aorta. So that's like fascinating. And I think that will allow us to bridge patients to transplant or destination therapy. So I think the way I look at it is a much simplified version, just as an intensivist like you guys. I don't overthink it. How do we manage these patients? I walk in the room, I go preload, squeeze, afterload, rhythm, pericardium, right side, same on the left side, so that I'm not missing. Preload, is the CVP high, low, right? Squeeze, every day, PAPI measurement. If you want to go one step further, every day, TAPSI measurement. What's happening with the TAPSI? What's happening with the IVC caliber? Then afterload, you may or may not have PA access every day, but what is going on with the PVR? Then is the patient in sinus rhythm? Then the left side, what's happening to the left side preload because of the right side? And then the left side afterload, right? And then we put it together and make sure that there is no effusion. Because if you have a large pericardial effusion, all your hemodynamics are off because you can't rely on your hemodynamics at that point. Then multi-system management. Let me tell you some pearls that I've learned. We need to actually write a paper. Probably have had like maybe 30 to 40, 45 RVAD so in my career that I managed. And one of the things that I love about the RVAD is how quickly you can get off the random pressors that we manage. We're like, oh, this patient is in sepsis, is in shock. That's the reason I'm on Levofed, which is norepinephrine, vasopressin, neosynephrine. There's no such thing. The patients have RV failure, behaves as vasoplegic shock, except for the CVP. Okay? You won't be able to tell. They behave as almost like cardiac cirrhotic vasoplegia. The only way that it is different is CVP is elevated, index is low. It is profound shock. So you want to avoid it. Don't wait until the end. If you're going to support them early. So the patient groups that we support early are post-LVAD RV failure. Post-LVAD, we see it quite often. RV dysfunction, we're very diligent in it. So when we walk in the room, we do early CVVHD. We absolutely make sure that we go down on the flow. Remember, we have to go down on the HeartMate 3 flow if the patient has profound RV failure, because the septal contribution to the RV contraction is near 30 to 45%. So if your LVAD flow is like, you're trying to go at like 4.2, 4.3 to optimize for the BSA, that RV is going to tank and there's nothing you can do about it. So you have to go down on the flow. And our HeartMate 3 is a robust device. It can handle no anticoagulation. it can handle. So compared to the previous axial flow devices, this is an amazing device. So what we do is we go down on the flow a little bit. We take care of the preload. We definitely do, in the everyone has their favorite inotropic agent. So dopa, dobutamine, milrinone, epinephrine, in whatever combination. So if you walked on my unit, if it is an LVAD patient, you'll probably see most of the patients on milrinone and a little touch of vasopressin, okay? Dopamine, if they are arrhythmogenic, doesn't work. Dobutamine is much cheaper than milrinone, that's fine. We have noticed a little bit of eosinophilia with prolonged dobutamine, so we prefer the more expensive milrinone, but that's also because we are not value-centric, which we want to become. Then we do inhaled nitric oxide with PVR optimization on these patients. Remember, we're doing even in the RVAD, because you can't go home with an RVAD, so we need to recover the ventricle. Then anticoagulation, I see one of the questions is anticoagulation strategy. We're just simple heparin people, unless we see platelet dysfunction and heparin-induced thrombocytopenia, then all of that, then we can go towards direct thrombin inhibitors. PTT 50 to 70. I'm a huge believer in D-dimer, not as a static thing, but D-dimer trends on these patients. Especially when you hold anticoagulation, and so that I know if there are clots or if we need to take things out. Then in the left side, we mentioned, what are the multi-system complications from specifically RVAD? I want you to pay attention to this if you guys have a limited experience. If not, you already know it. When you put in large cannulas on the right side, it's really important to not put in a lot of lines on the left side, okay? In ELSO, they saw a signal in patients that have had upper extremity cannulas that there is increased intracranial hemorrhage, okay? And the idea is that the venous drainage may be impaired because if you have two cannulas sitting like this near obstructing. So make sure, so when we have an RVAD on this side, we typically leave the other neck empty. We are looking and screening for clots and such, okay? But they tolerate it very well, usually. Then in terms of anticoagulation, I told you, the third thing is the lung. With the longer the patient is on a right ventricular assist device and the flow is increased to the lungs, the incidence of spontaneous pulmonary hemorrhage increases. And that's a pain when it happens. SPH is a known entity, known complication for RVAD devices. So who gets SPH and stuff? We are trying to understand because most of us have just case reports. We are diligent. We just, we put the patient on an oxygenator and convert it into a VA ECMO if needed, okay? We don't give up on the patient clearly. Like we've done IR embolization. We've done TXA nebulizers. We get interventional pulmonary, but they're barely able to do anything because this is the back bleeding. It's not like something that happens. We tell our respiratory therapist not to do deep suction because these are anticoagulated airways. We do red rubber. This is another clinical pearl that we learned, is that when your CVP is really elevated and you're in profound RV failure and you do a tracheostomy, we've noticed trach bleeds, okay, because these veins are like really engorged. But once you do an RVAD and you truly decompress, that does go down. We're really good here. We're one of the busiest shock units. We're so busy, we haven't written about all our experience, and that's the reason now we are trying to connect back with the world, coming out of our like little caves. But be mindful of that. Like, don't dismiss sudden hemorrhages that you see in the lungs. They happen. It's the nature of the game. We just have to be mindful and have like a systematic approach to teach. Just like, I don't know if you all do CTEF surgeries. I take care of these lungs the minute you go on an RVAD as if the patient had a PTA. Like, I'm like, the complications are the same, bronchial artery embolization and all the hemoptysis, having a right team behind them. Early mobility, We have seen a lot more mobility that we were able to achieve without cannula migration with RVAD Centrimag, meaning surgical RVADs. But my surgeons, I would love, Venkat, one day I would love to introduce you all to Dr. Manish Patel. He's our main CV surgeon, but he's very innovative. And so what he does to help us is that the PA cannula is a direct cannulation, like a surgical cannulation, but the drainage cannula, he does it subclavian, coming from the left side and draining, similar to our VV ECMO. And that has really enabled us to walk patients without worrying. The other way it helps is it truly, because it's really coming down into that RA IVC junction. It truly decompresses both the SVC and the IVC. Remember, you're only going to be as much supportive as what comes in, but I think all of them are really good. He's done, if the patient is super sick, we've even done a femoral cannula draining, and we walk all our femoral ECMOs, provided you can walk them, like the air hunger. Now, in terms of your point about air hunger for ARDS, VV ECMO, RV failure, I don't know. I think that RV dysfunction happens in VV. I'm part of the Delphi group that wrote the paper on RV injury in ARDS. I really think that I remain humbled. I think we're barely at 20-30% of our understanding. I think not all patients will have it the same way. I think it depends upon, do you have pulmonary thromboembolism? What is the nature of your RV failure? But I am absolutely RV centric, but I think I do a lot of pulmonary vascular disorders, so I'm also PA centric. I think if we have a dedicated approach to going into the room, every patient, and go preload, squeeze, afterload, right side, preload, squeeze, afterload, left side, then we can manipulate with pharmacologic therapies. But I think what we have learned over the last, I deal with M&Ms for my service line from quality. Everything comes down to three things. Selection criteria, you put the device works great, you put it in the wrong patient. Number two, you did not put it early enough. Okay. Number three, this is the most important thing that I've learned over the years in device critical care. We don't let go of our patients soon enough. Everyone in the room, even the cleaning lady, knows that this patient is dying, except the intensivist. So I think we are responsible. I'm now getting into palliative care and writing papers and understanding national trends in palliative care. I think giving a good death is even more important as doctors than just giving life and keeping them alive. Okay. So I think those are my clinical pearls, and I'll keep, I'm here. If you guys end up putting any of the Yashodas, end up putting someone on the device, just reach out to me on cell phone. And I have interventional cards here, CV surgeon. We can really support you guys from the cerebral standpoint.
So, Dr. Bindu, thank you very much for that overview. Just to take you, so again, oversimplifying things, patients who are on VV ECMO, what are the 3 or 4 clinical pearls? You already spoke about preload, squeeze, and all, but what are the 3-4 things which will point towards a RV failure for all our viewers?
I think one of the best clinical pearls that I have is, in the beginning when I was doing VV, we did not do POCUS enough times, frequency of POCUS. That's number one. I think we get like very comfortable with oxygenation, and I want to disconnect oxygenation to RV dysfunction. Okay. Just because the guy's oxygenation PaO2 has improved does not mean your RV is okay. I think after a while, when you're flowing into the right ventricle, like 4 liters of flow, and your PVR is optimized, right? Now you're causing secondary RV failure, just because you're like, I really want this guy to be on VV for a longer time. So clinical pearl there is you physiologically have always, Occam's razor is what we're all internal medicine or anesthesia, wherever you're coming from, you want to go, what is the big picture? What is the main problem? I want to deal with it. But then once you're on a device for a week or week and a half, you have secondary problems because of the device. Now the device is like a human being in itself, right? So you need to address the complications and the adverse events the device is causing, whether it is emboli, whether it is causing or contributing to RV failure. Early recognition of irreversible RV failure ain't going to help anybody. So you need to recognize it early. Persistent AST, ALT elevation.
Okay.
Persistent AST, ALT
What are the
elevation.
times you consider?
Yeah.
5 to
Persistent,
10
that's
times?
number one. Despite aggressive diuretic or ultrafiltration.
Okay.
I think the second clinical pearl is we are so focused on the damn oxygenation, we don't keep the lungs dry. I think a VV ECMO patient that is on standard rest settings of 10/10 of mechanical ventilation is a dead patient. A true patient is you walk in and go, where is my PVR? Is my lung adequately open enough? Am I causing PVR elevation? Am I over distending it? Am I causing atelectasis? Am I under distending it? And why am I not on a diuretic? Okay. Why? There should be a damn good reason if somebody has positive balance on VV ECMO. If their creatinine is normal and BUN is normal, okay, and they're puffy, like we're behind the game by like 7 days.
Okay.
Right? I like seeing the BUN of 35. I'm like, okay, you've dried enough. You can back off now, you know? Like because the kidneys can handle it. That's the second clinical pearl is keep them dry, keep the lungs open. I'm a believer in lungs open. I don't think, I know there's some people that do even like, oh, there's a pneumothorax, I'm going to do PEEP of 0. I think that is not okay. That's basically fetal circulation. We are not made for fetal circulation, okay? So I really think the lungs need to be open. That's number 2. Number 3, clinical pearl on VV ECMO. If I am seeing blebs, you know, those nice little like, and people don't say, I'm a pulmonologist, so I'm very lung centric too. If I'm seeing little black blebs, that is end stage emphysematous lung disease. That is, yeah, you may get the patient to an FiO2 of 40% on the vent and a trach, but that ain't a patient that's going to go home and live a full life. Lung transplant. If I'm seeing a bleb, I'm putting the VV ECMO, I'm ambulating the patient, I'm sending them to, I mean, you guys are a big lung transplant program in Hyderabad, right? Like you're getting a lung transplant because that the rate of recovery on these patients with that many blebs to live a good life is very, very little. They're just going to go to a nursing home and get a pneumonia and you're done. What's the point of like your 6-month expedition on VV ECMO and rehab and everything else?
So you've been
Those are just my 3 pearls.
So I think
Protect and preserve lung function.
Yeah, I think many of us has come through that experience where AST, ALTs were 5 times, 10 times, then slowly it went on to 100 times.
Yeah.
And we keep on initially diuresing and then VVHDF. And then we have to a stage where there is also a point of no return, as you said. So
Yeah.
the other components, other than VA, VV, we are talking about VPA ECMOs. And you have been seeing also.
Okay, so I'll tell you guys, I don't know the Northwestern folks personally and the University of Chicago folks. When they first came out with that paper, right, 80% survival, I was like, oh my God, what am I doing wrong?
Yes.
Because I was leading, you know, for our VV ECMO program, I was the lead here. And I worked with great cardiologists that are like more than even before vaccines. I'm telling you, we're only as good as we are because it's a phenomenal team. And it's a lot like we have Dr. Biswajit Kaur, who was AFMC trained. That's my main mentor. And he was like, you want me to take him to the cath lab? We'll put in the Protec Duo. I think the idea that you give oxygenation straight up and you decompress at the same time is physiologically absolutely one of the best things that you can think about. But sometimes the same physiology doesn't connect to that individual patient for whatever reason. And I'm going to tell you some clinical pearls. I have to back it up with data. I don't have data. I collected blood, but we haven't analyzed it. I present to you that VPA ECMO in early, like we're not talking dead lungs that are, like that maybe day 13 ARDS, day 14, not fibrotic, not emphysematous, whatever. I think is great. You put them in, the lungs are not dead. You're getting that transient oxygenation support. In my opinion, during COVID, we did 120 VVs, right? Early on, we tried every formulation. The only one that gave me the most robust support was femoral and IJ VV ECMO.
Okay.
Fem IJ allowed for, and we didn't have recirculation because what we did is Manish, our surgeon, his drainage cannula and the return cannula, right? He parked it deep inside the RA so that he really suctioned everything. And then the return cannula was aimed at the tricuspid. So we had that, and I was able to walk the patients without that much recirculation. The VPAs just didn't give me the robustness of support towards the third, fourth, fifth, sixth stage of ARDS.
Okay.
Then I'm like back on inhaled nitric oxide, back on ventilatory support. So if you have that early ARDS recoverers, like the Chicago group, so what we were discussing is maybe they did do it early enough and those patients luckily did not progress and they were able to decannulate. But we are a big hub and spoke model. So almost I get deathoid patients. Literally the door right before the heaven, like that's where they're dropped off and I pick them up. I don't get any earlies. So that's how I reconcile that in my brain, is that they must have gotten early, because I definitely did not see that. I did not see the improvement as they did. Number two, females, in my opinion, I don't have data except for my own patients. When we did that and we contributed to dural vein stasis or whatever else, I had a hazard ratio that is twice as much of intracranial hemorrhage. Okay. And I couldn't explain. And I was like, I'm not playing this game. I'm going to play the game that I know, I know well. Okay. Because it was a great area, right? Like, I mean, we were getting ECMOs. I was running 17 ECMOs, guys, at that time. 17 ECMOs at singular time for like those 2 years, right? So we could do any RCT you want. And then I was like, because you can't tell me the estrogen axis in a 40-year-old, a menstruating 43-year-old, a young 26-year-old, they're different. And I think that contributes to the coagulability and the friability and the dural vein. So we didn't realize that until like we had two that immediately, and I was like, I can't explain. And then I was like, oh, these are the upper extremity cannulas. These big cannulas are blocking. Otherwise, there's no reason for them to get spontaneous ICHs. So I want you to think about that persistent AST/ALT, but I think you need to be really on top of your game, because if it's almost that like by the time that happens, the cat is out of the bag,
Yeah.
And it's an expensive device. So my thing is, if a FemIJ does the same trick, why do you want to do something that is 4 times more? And I think, and people are like, oh, but you can walk the patient with, with these VPAs and the crescents and stuff. I'm like, well, I didn't used to walk my VVs, but the minute my physical therapist got around and the surgeons and the therapists, the surgical PA make sure that the cannulas are sutured. The minute you get your program into a walking VV program, you keep telling me about economical ECMO in India. That's your economical ECMO.
Okay. What is a PA balloon counter pulsations role in these kind of things, which we do IABP here in for maybe some of the reasons, but what is the role of a PA balloon counterpulsation? Is there any role? We were talking about it, or we were hearing about it. Is there any role of that?
No, I mean the data. Hap Farber is at Tufts, and Hap Farber is like I think almost 80 years old. He was my professor when I was up in Boston, and he's trialed it in patients. And basically the idea is that just like the left side, you improve the right side's ability to squeeze against that high PVR. Naveen Kapoor developed the device, and now that device is just bought by Abiomed. So they haven't had any trials on that. So I wouldn't go after it. But I will tell you that I think in the future, if you guys want to try it, we haven't. The question is now tricuspid clips are becoming more, right? Just like mitral clips, tricuspid clips, just that like if your integrity of the right ventricle is gone, are we like really like late to the game and think that our epi, dopa, dobutamine are going to do it when what you needed is a structural intervention, you know? And I know that none of the cardiologists get excited about ARDS, especially with ARDS induced RV injury. But I think we all will be talking about the role of tricuspid interventions in secondary pulmonary hypertension, which is what ARDS is, right? That's group 3, and RV failure. So I think that's there. But I don't think we need to go there yet. I think we need a lot more data on that.
You have been repeatedly mentioning about the vascular resistant PVRs as a calculation. So you said we don't use many of a swan gaze in many of our patients when you have already a large cannula in IJV. So what is the alternative way where you measure this PVR?
I think that's a very good question. I'm also late to the game. I wish over the last I've been out for medicine for 21 years now. I wish I got better at echo, and I'm trying to. I think PVR just by measuring tricuspid regurgitant jet is very 15 years old. I think we need to get comfortable with the concept of RVOT acceleration time. I think we need to be looking at mid-systolic notching in that RV outflow track. You know, the RV goes into the PA, right, in the short axis view, like to measure it and to see if the mid-systolic notch is developing. There's like PI, early diastolic. These are all non-invasive.
Echocardiographic, non-invasive way where you actually suspect. As you rightly pointed out, if the resistance is high, you may use any device. It's of no use. So what are the other medical?
VA ECMO.
Yeah. So what are the medical therapies used? We use nitric oxide, use prostacyclins and all. Any of these medical therapies which you use in those situations to improve your vascular resistance in those situations?
So the first case was a straight up PAH case, right? So I'll tell you, so we have 4 medical institutions on the same street. One of the county hospitals sent me a Pakistani woman that had that basically had a baby 6 months ago and had pre-syncopal episodes and was coding left and right. So the patient comes in. On arrival, we put in a patient on VA ECMO. She was very young. So, and then when we looked at the PA, when we do with the echo, RV was humongous, PA was generous, but when we floated the swan, PA systolic was like 30, right? Now the patient is already on VA ECMO, so you can't even show that the CVP is elevated because, you have complete VA ECMO that is supporting the patient. The only thing that we could go by was the pre-code echocardiogram. So my team was like, oh, why would you do VA ECMO in PAH? And we were like, well, bridge to recovery. The same patient, if it was an LV failure, the team would have been much more on top of it. But the minute you say PAH or an RV or a lung issue, they're like, this is a death case. It's like, why is it a death case? I mean, it's the same thing. Let me support the patient. So we put the patient on Velletri. Velletri is epoprostenol. Started 2 nanograms, 4 nanograms. I parked it at 20 nanograms, which is equal to treprostinil. I don't know if you guys use treprostinil, that would be about 40 nanograms. And I was able to wean the VA ECMO. This patient comes to me and sees me in clinic. She's still on Velletri. So absolutely. VA ECMO is a bridge. The minute you get on the bridge, every minute, how do I get this patient off this bridge? Where do I go from here? That's the sense of emergency we need to have.
Thank you. Thank you very much. It was a insightful, and it's a beyond medicine with a lot of wisdom and yeah. Doctors,
Yeah,
please.
no, but we are here. We have, and all of us, I think we need to learn together. We want to learn. I want to learn more in the economical sense, how to do value-based ECMO, because I think that's where we are headed here.
Probably being put across the LV venting, which we actually been ideally, as you said, a Impella can be a device there, and 5.5, which is I think a revolution in LV venting. The problem here is the cost.
Yep.
I don't know, in Indian currency, it comes somewhere in 25 to 30 lakhs.
I think Sri Charan, since you only have 10-bed ICU, you need to work with some engineers and develop a Yashoda Pella.
Charan, the Impella 5.5, is it available in India with the 5.5?
As far as I know, the only Impella which is available in India is CP. We don't have 5.5 available. We don't have RP available.
And
yeah, I think they were working on it. I have Bobby Bogue deals with the 5.5 for global. I can connect you guys. It's all about like the government approval and the price and stuff.
So,
but I really think, and my question to you is, granted that they developed it and Impella CP is available, why, if we can develop vaccines, if we can develop, I just don't understand. I think there's something that my brain's not clicking. We export the most number of engineers from Hyderabad and Andhra here, yet we can develop an axial flow device. It just doesn't make sense. And we have the human power, we have the bandwidth. I think it's about the need, and I think we just need to figure out how to get that done.
Agree.
So devices we are struggling with even. Charan, we are also struggling with the circuits availability. The MAC circuits are in short supply in the last 3-4 years, not now, and we have been juggling with many combinations. Charan, I just wanted you to give some input. So we have done a study with a 40-50 patient with Ravi Krishna also being a part of it. Dr. Bindu gave a complete overview of all that. What is your take on that? Any questions from your side? You have been very actively part of it.
Not much questions, sir. It was a very comprehensive discussion. The thing is, the one thing what we noticed is that theoretically speaking, a patient who is having ARDS and who will have some degree of increased pulmonary pressures, and after we initiate the patient on an ECMO, we will be thinking that because we are essentially flooding the PA with oxygenated blood, we will be coming down on the hypoxic pulmonary vasoconstriction, the PA pressures come down and all. But ironically, there are patients who have developed RV dysfunction after initiating on a VA ECMO. So that is something, when we actually looked at that study, the incidence really surprised us. So it is like good number of patients, almost 25-30% of patients whom we did not expect to have any pre-existing RV problems, developed new onset RV dysfunction on a venous ECMO in spite of correcting the holy trinity of RV dysfunction, hypoxia, hypercarbia, and acidosis.
Because you were late to the game.
Yes.
Because either number one, when the patient was on VA, you put in the wrong device because they should really be on isolated LV support. Now you have secondary pulmonary hypertension because there's an adverse event for using VA ECMO to bridge LV failure. And now you're dealing with the RV failure aspect of it, right?
We know venous, actually.
Yeah, we know venous. I think we have to take it. Right now, we do not have the right lung support device.
Yes.
It doesn't make sense, right? The lungs are injured and we're pouring blood into a pulmonary artery.
Yes.
Even that doesn't make sense, right? The lungs, the actual alveoli are injured, and you're like, okay, here's blasting, non-pulsatile, continuous flow, oxygenated blood. And we know in our head that oxygen is the worst thing for the lungs, hyperoxygenation. So you have dead alveoli, you have new leaves, you have old leaves, you have dead leaves, and you're like, for all of them, I'm going to give you a PaO2 of 400. The dead leaf is going to be like, you're wasting your time on me. The new leaf, the new budded leaf is like, dude, high oxygen tension, I'm going to die. And then we're going to give the PaO2 of 400 anyway, right? And then, so I think we are so behind in lung technologies because we, as intensivists, we need to do a better job. And I think we're sitting in the wrong, we need to get into engineering spaces. So I'm working with somebody on understanding bronchoalveolar stem cells. Did you guys know that in Singapore, there was a lab that looked at autopsy specimens for ARDS patients? And they were really surprised where they found the bronchoalveolar stem cells. It was not in the dead areas. The lungs that were gone, it was gone. It was actually in the semi-recruited areas that they are. So we have to come up with like, where are we giving the blood supply? Because we're taking care of the lung as if the whole lung is the same. But we understand during COVID and stuff, there's baby lung, there's recruitable lung, there's dead lung, and all of those zones, right? So I think right now, for what we have, yes, RV injury after VV ECMO is, I think it's an underestimate of 30%. I've had patients on 160-day, 180-day VV ECMO runs. It's a natural history of lung, you know? You're seeing what happens with dead lung is protected. Like, I think it's going to happen, and it's much more. It's probably more for like 50 to 60%. If you really looked at it. But yes, VV ECMO, Protec Duo, or RPA, or, you know, whatever you want to call it, RVAD oxy support. Then Veen. We used a lot of ECOR by A-Lung Technologies during COVID. So we were able, because we had 17 patients and not enough McKay devices, what we did is if the patient got off of the oxygenation and it was just a sweep issue, then we weaned it to ECOR and then out. Or we bridged up ECOR plus vent to VV ECMO, then VV ECMO plus ECOR, VV ECMO out, ECOR out, done. Or lung transplant.
We've done that in one patient. We had like where we had to wean a patient from VV ECMO to ECOR, and VV ECMO was a 20-day run and ECOR was a 15-day run. So later we were able to wean the patient off ECOR support.
No, that's awesome. So yeah, I think we need to continue to learn and push industry to do better.
Thank you, Dr. Bindu. Thank you, Charan. I think it was.
Thank you so much for having me, guys. This was very nice.
So we will connect more frequently. We will keep on probably knocking you whenever.
Yeah, and anytime you have cases, we are happy to share our cases too.
Definitely.
We've had so many deaths on VV. The last 4 out of 5 died. So we don't have it any better either. I'm being honest. Like, I think we have a comfort level, but I think we don't have a selection down, you know? We don't have the selection down.
Here in India also we do face the same kind of things. You don't have a selection. The families, the patients, the clinicians who can afford, who can actually have a kind of doing that. The other patients who are actually ideally suitable, but there are many challenges. Actually,
of course.
So the same problem goes around, but we will try to learn from you. I think Charan and my team will be in touch with you. It was a wonderful meeting you, and we wanted a meet to start, and it was wonderful. In future also, we will be more than happy to invite any of your team members, surgeons, your boss, to have more interactions. And
no, we should. It's high time. I've always wanted to become first, like, good at the bedside before I shared my knowledge. Then I realized that I was like too much at the bedside.
And most of it is from your honesty, your transparency.
Yes.
So you speak our heart out. Charan and me had many nightmares where we were thinking about these bad outcomes, and what are we doing? Where are we?
Yeah.
What next to be done?
Yeah, it's a definitely an improving science, but what I have to offer for you guys is all this energy. I submit to you, you better be working with an engineering company. If the biggest export of Andhra Pradesh is engineers and software engineers and AI engineers, it doesn't make sense that we don't have a device that is coming out of India.
So, ma'am, we will carry that. I think there are some programs going on for the circuit from Make in India. Hopefully, this will also be a part of it.
Okay. Thank you, guys.
I conclude. Thank you.
Yes. Okay. Bye.
Bye-bye.